Okay, so when we talk about hypertension, as we did allude to in the first lecture, you have primary hypertension and secondary hypertension, but a lot of what we call primary hypertension should be really classified as secondary, because remember what we said about obesity. It accounts for a significant uh, proportion of or hypertensive individuals, alcohol consumption, and dietary indiscretion, salt intake. So, but we still classify those as primary hypertension. So when someone comes to you for the first time and they're found to be hypertensive, and remember, we have it's a precise diagnosis. Not coming to the office one time and they're not coming to the office just once and you check the pressure and the pressure is elevated. No, there's a specific way to do it. So that is why it's important for you to review the there's a specific way for you to make the assessment. So you need at least a minimum of 2 blood pressure recording on 2 or more occasions. So you're not going to the patient, don't come to you for the first time, and you make the assessment. Okay. So once you make the diagnosis of hypertension, there's some basic blood tests that you need to do. You need to do a fasting blood glucose, complete blood count, lipid profile. Make sure the kidneys are functioning, make sure the patient is not anemic, look at the thyroid, uh, check the urine, make sure the kidneys are okay, get a 12-lead EKG. You want to make sure is there target organ damage, which would manifest itself like LVH. You want to get your echo, look at the ejection fraction, look at wall thickness, uric acid, and you want to get urinary albumin and creatinine, and can look at the ratio. So these are some basic blood tests for common primary hypertension. We used to call this essential hypertension. If you're suspecting a specific secondary cause, however, because of the examination or something from the history, then there are additional blood tests or additional tests that you need to do. But these are just the basic tests that you want to start out with, okay? Because you don't want to be treating someone for hypertension and then 2 months down the line you realize that the BUN is 50 and the creatinine is 4. You don't want to run into that problem. All right, so let's go back. So secondary forms of hypertension accounts for about 10% of hypertension in adults with hypertension. So majority of your hypertensive patient is going to be primary hypertension. But still remember that 10% of those patients, all the patients with hypertension, going to have some form of secondary hypertension. So when the patient comes, as you evaluate all your patients, you're going to get a history, a detailed history. Then you do physical examination and the basic lab tests. From the history or the physical examination, if there is a specific secondary cause, it will lead you to that. Say, for instance, if the patient tells you that, kidney disease runs in the family, polycystic kidney disease and stuff like that, then that's going to tip you off that, the patient may have some renal problem. They may give you additional history to suggest that there is renal compromise. Or if the patient have coarctation of the aorta, they may tell you that, they were told that they have a bicuspid aortic valve, and when, on your physical examination, you'll find that the pulse in the lower extremities are weak, whereas you have bounding pulse in the upper extremity. And there are things that we look for, we call, radiofemoral delay. So there are things in the history and physical examination that will tip you off. So make sure that your history and physical examination is fairly complete. Okay, so I'm going to put up a lot of boxes looking like this. And basically what this box is telling us, or this type of information. So whenever we're doing any tests, or we're doing any procedures, or we're prescribing any medication, we give it a class. And this is the class of recommendation. So the class of recommendation can be class 1 all the way to class 3. Class 1, it's color coded green, because if it's a medication, it should be prescribed once the patient satisfies the criteria for prescription, or if it's a procedure, once the patient deemed necessary for the procedure, then they should have it. So class of recommendation goes from 1 through 3. Class 2 is divided into class 2A and a class 2B. You should do it, but if you don't want to do it, then that's fine. Class 3 is a contraindication, and not only a contraindication, but sometimes it may cause the procedure or the medication or whatever may cause harm to the patient, so it should not be done. So the recommendation for secondary forms of hypertension, class 1 indication. So you should screen for specific forms of secondary hypertension. So it is recommended when the clinical indications and physical examination findings, and we're going to look at those, presents in adults with resistant hypertension. So basically what this is saying is that if someone presents with hypertension, resistant hypertension, and we'll go over what is the definition of resistant hypertension, you should screen for a secondary form of hypertension, especially in a young patient. So if you get a patient coming to you less than age 30 with hypertension, and especially if you get something in the history that suggests that you should do a screen for secondary cause of hypertension. And a class 2B. So we also have a level of evidence. So this is level of evidence. So the level of evidence goes from A to C, where level A would be, well recommended. There's a lot of scientific literature and studies supporting that you do whatever you need to do. So class 2B, if an adult with sustained hypertension screens positive for a form of secondary hypertension, then that patient should be referred to a physician with expertise in hypertension. Okay, so what they're saying is, if you find the patient to have, say, Cushing's, that's something that can give rise to a secondary form of hypertension, then you need to refer that patient to a hypertensive specialist. If the patient is found to have coarctation, you definitely have to refer that patient to the appropriate specialist. All right, so again, when we talk about secondary form of hypertension, if someone presents age 30 or less with hypertension, that is a tip off that you need to do some additional evaluation. Okay, there are a lot of secondary causes for hypertension, but the more common ones is what we call primary aldosteronism, renal artery stenosis, and obstructive sleep apnea. So people who are doing exams, these are the things that they usually put on. So these are the most common cause for secondary hypertension. And you should know how to work these patients up. You should know how to evaluate these patients, okay? So a young patient present with hypertension, what you're going to do. So this is a fairly exhaustive list of all the secondary causes for hypertension. Renal disease. So patients have chronic kidney disease, as we mentioned, polycystic kidney disease, which runs in family. That's about 1 to 2% of your secondary hypertension. Renal vascular disease now. So patients who have chronic kidney disease, this is blockage of the blood vessel going to the kidneys. And we usually talk about two types. So in an older patient, it's most likely atherosclerosis. So people doing exams again. Older patients with renal vascular hypertension, it's usually atherosclerosis. And then the younger patients, they will have what we call fibromuscular dysplasia. Okay? And you should have an idea of how these patients are worked up. Primary aldosteronism accounts for about 8 to 20% of your patients with secondary form of hypertension. So when you have a patient who presents with resistant hypertension, you should always think at the back of your mind, is this primary aldosteronism? A lot of these patients will have hypokalemia, low potassium, so they sometimes will present with weakness. They'll present with a little bit of weakness, and when you check the potassium, it's low. So you have to know what additional tests you need to do to work these patients up. Sleep apnea, 25 to 50% of your patients with secondary hypertension will have sleep apnea. So always get a detailed history, snoring, daytime, somnolence. Okay. And even though we don't think of alcohol as a secondary form of hypertension, but a lot of people drink, 2-4 drinks per day, and they will develop significant hypertension. Pheochromocytoma, it's not very common as a form of secondary hypertension, but they love it on the test. So that's the only reason to know about pheochromocytoma. It's very, very testable. These patients will present with hypertensive crises, and you have to know how to manage them. Cushing syndrome, not very common, but it can cause hypothyroidism, and hyperthyroidism can also cause secondary hypertension. Aortic coarctation, remember, what aortic coarctation is a narrowing of the aorta, usually at the region of the left subclavian vein. And so you'll have hypertension in the upper body, and the pressure in the lower body will be low. Congenital adrenal hyperplasia produce a lot of aldosterone, and as a result, you can get hypertension as well. Mineralocorticoid excess syndrome. This is not primary aldosteronism, and growth hormone excess acromegaly. All right, but the common ones that you need to know about is the primary aldosteronism and renal artery stenosis. So we're going to spend a little bit more time on those, because those are the conditions that you will see in the community. Primary aldosteronism is basically a group of disorders in which aldosterone production is inappropriately high for the sodium status of the patient. So increased aldosterone production from the adrenals, and as a result of that, you get hypertension. And the potassium is going to be low because of the increased sodium potassium exchange in the kidneys. The potassium is usually low in these patients. The thing about it, these patients with primary aldosteronism, you cannot suppress the aldosterone production by giving them a high sodium load. In a normal individual, you can suppress the aldosterone production from the adrenals by giving them a lot of sodium. We talk about sodium loading. So you can't do that with these patients who have aldosteronism, because it is the production of the secretion of the aldosterone is not dependent on any outside influence. So when you do your so the increased aldosterone give rise to the hypertension, and the hypertension will cause cardiovascular and kidney damage. So it's necessary for you to make the diagnosis and then treat these patients appropriately. So as we said before, these patients have sort of automatic production of aldosterone. And as a result of that, you get sodium retention. Okay? The sodium retention causes suppression of the renin activity. Okay, so these are stuff that goes on in the kidneys, and because of the suppression of renin activity, you get increased potassium secretion, and as a result of that, low potassium, hypokalemia. So all of this is because of the increased aldosterone. Okay, again, increased aldosterone, you're going to get sodium retention, and then you're going to get increased potassium loss in the kidney and hypokalemia. Even though hypokalemia is a feature of primary aldosteronism, a lot of these patients do not have hypokalemia. So if you don't see hypokalemia, don't rule out primary aldosteronism. So how do we make the assessment? So we'll discuss how I make. So in adults with hypertension, screening for primary aldosteronism is recommended in the presence of any of the following concurrent conditions. So you're going to look for primary aldosteronism if the patient have resistant hypertension. And even though we have not discussed resistant hypertension, basically it's a difficult to treat blood pressure, or blood pressure that requires a lot of medications to control. So if the patient have difficult to treat hypertension, you're going to suspect primary aldosteronism. If the patient have hypokalemia, low potassium, it may be spontaneous or it may be induced by the diuretics. So, or if you incidentally discover an adrenal mass. The patient may also have a family history of early onset hypertension or a stroke at a young age. So the evaluation of these patients is class of recommendation class 1. So if someone have resistant hypertension, hypokalemia, early family history of hypertension and stroke, you have to work them up for primary aldosteronism. It's a class 1 indication. Level of evidence C. Class 2, also class 1. The first thing you're going to do if you suspect primary aldosteronism, remember primary aldosteronism is when the aldosterone level is high because there's an automatic production of this aldosterone. You're going to get a plasma aldosterone to renin activity ratio. That's the first test you're going to get. If it's elevated, then you do additional tests. But the screening tests for primary aldosteronism is a plasma aldosterone to renin activity ratio. Okay? And then if that ratio is elevated, and the number you need to remember, I think, is 30. If it's above 30, then, I'll show you the additional workup. But once you make the assessment of primary aldosteronism, you have to refer these patients to the appropriate specialist, hypertensive specialist or endocrinologist. Okay. So we're still in primary aldosteronism. Automatic increased production of aldosterone, which causes sodium retention, hypertension, and you get hypokalemia. 50% of these patients are going to have unilateral aldosterone production. That is just on one side, okay? So they may have an adenoma, which is a tumor, or they may just have a unilateral adrenal hyperplasia. That is, when we say hyperplasia, there's increased cellularity, which causes the production of the aldosterone. Or it could just be a tumor, adenoma, but 50% is going to be unilateral. And then the other 50% is bilateral. Okay, so the other 50% is bilateral. About 5 to 10% of these patients with hypertension usually have bilateral adrenal hyperplasia. And about 20% of these patients have resistant hypertension. All right, so remember we said the first thing you're going to do is do your aldosterone renin activity ratio. Since they're producing a lot of aldosterone, then it's going to be high, and the high aldosterone is going to suppress the renin activity, so the ratio is going to be elevated. And the cutoff we're looking for is 30. So the aldosterone to renin activity ratio greater than 30 is suggestive. It's a screening test, so it's not diagnostic, it is suggestive. Then the confirmatory test now is when you do the intravenous saline suppression. So remember, in a normal patient, you can suppress the aldosterone production by salt loading them. You can load them with salt. So you can do that either oral salt loading, or you can do intravenous salt loading. Okay, so the screening test is the aldosterone to renin activity ratio, and then the confirmatory test is the saline suppression. If it's not automatic production, you should be able to suppress the aldosterone by salt loading the patient. All right. So if you give them salt loading and you could not suppress the aldosterone, then you confirm it's primary aldosteronism. The only problem, though, is that it could be bilateral or it could be unilateral. So if it's positive, so you confirm the test, you confirm it's primary aldosteronism, you do what we call adrenal venous sampling. So what you're going to do, you're going to sample the veins coming from the two adrenals. So you're going to sample them. And that way you can distinguish if it's unilateral production or bilateral production. And it's very important to make that distinction. So you sample the veins coming from the adrenal, and if the elevated aldosterone is just coming from one adrenal, then you can do adrenalectomy, unilateral laparoscopic adrenalectomy. Basically, you remove that adrenal and you cure the hypertension. So if it's unilateral aldosteronism, you can just remove that adrenal and get rid of the hypertension. If it's bilateral, you can't do that though. You can't remove both adrenals. So if it's bilateral, you can use spironolactone, which will suppress the effects of the aldosterone, or you can use eplerenone for bilateral. Okay, so that's primary aldosteronism in a nutshell. Screening tests, the aldosterone to renin activity ratio. Anything above 30 is suggestive. Confirmatory tests, salt loading to see if you can suppress it. If you cannot suppress it, then you make the assessment. Okay, you confirm it. And you do adrenal venous sampling to distinguish whether it's unilateral or bilateral. Remember, and you'll in the process you'll also do some imaging. You might want to do a CAT scan, okay? But remember, if it's an adenoma, yes, you can see that. But if it's not an adenoma, you won't see a mass. Okay. All right. So again, people doing exams, they have to know aldosteronism, primary aldosteronism. The next fairly common cause for secondary cause for hypertension is renal artery stenosis. And renal artery stenosis, there's a narrowing of the renal artery, which result in a restriction of blood flow to the kidneys. In older patients, it tends to be atherosclerotic, and in younger patients, it's non-atherosclerotic, fibromuscular dysplasia, most likely. All right, so don't rush these patients to get a stent or angioplasty and stent. Some people will send these patients to have procedures to open the renal artery, but it has been shown that endovascular procedures provide no benefit over medical therapy. And there are specific indications to do something that is angioplasty or a stent. So it's not automatic that the renal artery is stenosed and you're going to do a procedure, because there's in most of the patients there's no benefit in doing these procedures over medical therapy alone. And when they look at the CORAL study, the cardiovascular outcomes in renal atherosclerotic lesion, optimal management that includes the renin-angiotensin system blocker, giving them adequate cholesterol medicine to reduce LDL-C cholesterol, and if you use sufficient, if you use antiplatelets, smoking cessation, and control the glucose, you can get very, very good results in these patients. So again, don't rush these patients off to get a angioplasty and stent. The patients who you're going to send for angioplasty or stents is those patients who do not respond to medical therapy. So make sure you do your exhaustive medical management, and then if they don't respond, then you can send them for angioplasty stents. Patients with Takayasu's arthritis and with fibromuscular dysplasia, so these are usually younger patients, then you can send them for angioplasty, okay? But not all comers, especially your 85-year-old patient who have renal artery stenosis, and our blood pressure is quite good. What about obstructive sleep apnea? So recently we have recognized that obstructive sleep apnea accounts for a significant proportion of patients with secondary hypertension. These patients, they have collapse of the upper airway during sleep. So the upper airway just sags and closes off the respiratory tract. Okay, so they have intermittent episodes of they stop breathing, or they may have shallow breathing. Okay, so they may be apneic or hypopneic, and so they become hypoxemia, develop hypoxia during sleep, and they have frequent sleep disruption. So what are some of the, well, we know that obstructive sleep apnea is one of the risk factors for cardiovascular disease. And we know that when we talk about cardiovascular disease, other risk factors are hypertension, coronary artery disease, uh, cardiovascular disease, heart failure, and atrial fibrillation. So sleep apnea can give rise to all of these conditions. So that is why it's important to, when you go through your history, you can get a history of, the spouse or significant other will tell that the patient snores a lot. There are periods when the patient is not breathing, and then the patient will have daytime somnolence. They're driving and they're feeling sleepy. They sit down watching television and fall asleep. That type of thing will tip you off. So the treatment for obstructive sleep apnea is CPAP. And, okay, so CPAP, continuous positive airway pressure, and if it's adjusted properly and the titration is good, you can have significant blood pressure lowering by just a CPAP. There are also other surgical techniques. Okay, there are laser techniques and other surgical techniques which can tighten up the loose upper airway and reduce sleep apnea. Also, dietary manipulation, alcohol cessation, and physical activity. So one of the important things when we talk about the treatment of hypertension is the non-pharmacological approach to the treatment of hypertension. Remember what we said, a significant proportion of hypertension is due to dietary indiscretion, weight gain, obesity, alcohol consumption. So if we can correct dietary aberration, if we can get the patient to reduce the consumption of alcohol, and if we can get patients more physically active, we can reduce blood pressure quite a bit. So there was a number of diets and approach that were looked at, and they were investigated in a randomized controlled trial. And the DASH diet was one of the, again, for people who are doing exams, the DASH diet was one of the most significant reduction in blood, cause reduction in blood pressure. And the DASH stands for dietary approaches to stop hypertension. And basically what that is sodium reduction, significant sodium reduction. So that's very important when you counseling your hypertensive patient. They need to reduce their sodium intake. Potassium supplementation, and as we had mentioned before, it is not taking potassium supplements, but dietary potassium supplementation, food rich in potassium. So that is essentially the DASH diet. And the other diet that was found to be very beneficial in patients with hypertension is the Mediterranean diet, which these patients reduce their carbohydrate intake, a lot of vegetables, legumes, beans, nuts, monounsaturated fats, reduction in red meat, so more white meat, and moderate intake of wine. However, if your patient is not a drinking person, I wouldn't encourage them to start. So looking at these non-pharmacological intervention in a little bit more detail, so you can see that weight loss can cause significant reduction in blood pressure. In a normotensive individual compared to an hypertensive, with a 1 kilogram weight reduction, body weight reduction, you get a much greater decrease in the blood pressure if the patient is hypertensive as opposed to normotensive. And then with the DASH diet, you can see the hypertensive patient have 11 millimeters fall in the blood pressure. And then reduction in dietary sodium also give you significant reduction in pressure. And dietary potassium also give you significant reduction. So when we talk about the optimal sodium goal is less than 1,500 milligrams per day. You should aim for at least 1,000 though, okay? So we're talking about significant sodium reduction. And the DASH diet, remember that. And then physical activity. So, the patients will say, when you say physical activity, doc, what are you talking about? So aerobic exercise, and we talk about a 90 to 150 minute per week moderate intensity exercise. So 90 to 150 minutes per week. So you can divide that, if they want to do 30 minutes per day and they do, say, 4 to 5 days, then that's fine. Or they don't want to do 40 minutes and they want to do 3 days. But the recommendation is 90 to 150 minutes per week. And you can see the reduction in the blood pressure. I usually recommend mainly aerobic, but you can do dynamic resistance, isometric. And then when we talk about alcohol consumption, remember the recommendation is not more than 14 milligrams of alcohol per day. So when we talk about a beer, it's a 12 ounce of beer, and beer, roughly about 5% alcohol. And then when we talk about wine, 5 ounces of wine, wine is about 12% alcohol. And then the hard liquor, if it's 40% by volume, hard liquor, then 1.5 ounces. So, but if the patient is not a drinking person, don't start recommend drinking. We went over how to accurately check the blood pressure, because if we make too much errors in checking the pressure, then we're not going to get good readings. Okay, so remember, the patient has to relax, sit in a chair, the feet should be on the ground, the patient back should be supported, and you want them to relax for more than 5 minutes. No smoking, no caffeine intake. So we went over all of this, so you need to review it periodically and make sure you're doing the right thing, right cuff and everything like that. So, and those are the same thing that you're gonna tell your patients when the patient goes home. Those are the things that they should do before they check their pressure at home. Okay, so again, some important features. We're talking about secondary hypertension. Say if you get someone who is under age 30 and they have elevated blood pressure, they have hypertension, and it's the first time you've seen that patient, you probably should get a thigh blood pressure as well. Okay, so young patient, hypertensive, get a thigh blood pressure the first time you've seen the patient. If the thigh blood pressure is lower than the arm blood pressure, then that's a problem. It's supposed to be higher. The pressures in the lower extremity is supposed to be higher than the pressure in the upper extremity. So if you get a consistently low pressure in the thigh, then you should suspect a diagnosis of coarctation of the aorta. Okay. So there's some things in the history or the physical examination that may tip you off that you're dealing with secondary hypertension. Okay. A younger patient may have episodic increase in blood pressure and present with hypertensive crisis in patients with pheochromocytoma. Okay, so those patients will present with hypertensive crisis, episodic elevation in blood pressure with dizziness. So of course we talk about the patient who's snoring, hypersomnolence, drowsiness, suspect sleep apnea, patients who have prostatism, suspect chronic kidney disease. If the patient have muscle cramps and weakness, it may be due to low potassium from primary aldosteronism. If the patient have excessive weight loss and palpitation, probably hyperthyroidism, fatigue, edema, frequent urination, kidney disease or kidney failure, and if the patient have a prior history of repair, coarctation repair, they can also have residual obstruction and upper body hypertension, uh, central obesity, facial rounding, easy bruisability, suspect Cushing syndrome. So pay attention to the patient when they come in to see you. Initially, I mean, it should be every time, but at least when you're seeing the patient for the first time with hypertension, do a precursory evaluation. You look at the medication they may be on over-the-counter medicines, or they may be taking NSAIDs. Patient may be using drugs, cocaine, amphetamine, stuff like that, and look for family history, because from the history and physical examination, a lot of time you can pick up the secondary cause of hypertension. And so the patients who you suspect have secondary hypertension, the blood test or the evaluation, the test that you're going to do, pretty similar to the primary ones. You're going to get your electrolytes, BUN creatinine, urinary albumin, TSH, sugar, CBC, ECG, the echo, MRI. You wanna, if you suspect the primary aldosteronism, remember you may get a low potassium. You need to do that aldosterone to renin activity ratio, and then so basic tests and look at the tests. One problem is the ECG. ECG is a little, well, I'm not going to say it's disappointing, because it might be how it's done, but the electrocardiogram, the criteria for LVH correlate very weakly with echo and MRI. So we'll get a lot of we'll get a lot of patients who have LVH on the electrocardiogram, and then when we send back the report, the echo report, and there's no LVH, some of the physicians are, surprised. But there's a very weak correlation between your ECG LVH and the echo LVH. However, left ventricular hypertrophy is an independent predictor of cardiovascular complications. So if the patients have LVH, it's a bad thing. Okay, it suggests that they will have some type, or they can have some type of cardiovascular complication. And so you should try and reduce LVH to reduce risk. So we went over the blood tests. So it's important to get the necessary tests. We're going to stop here because we don't want to spend too much time on that. But we're going to, when our next session, we're going to go a little bit more into treatment. But the first treatment that all hypertensive patients should have is lifestyle modification. We talk about weight reduction, diet, we talk, cessation of alcohol, and physical activity.